Hi everyone, welcome to Pharmacology. So in our last session we have discussed about anti-cancer drugs and there we have learned three most important classifications which includes antibiotics, then antimetabolites as well as alkylating agents. So today we will continue with the remaining classification as well as remaining portions of anti-cancer drugs. So the next most important category of anti-cancer drugs is microtubule inhibitors. So what is a mitotic spindle? This mitotic spindle is a part of a larger intracellular skeleton which is known as the cytoskeleton that is essential for the movements of structures occurring in the cytoplasm of all eukaryotic cells. This mitotic spindle consists of chromatin plus a system of microtubules, and this microtubules is composed of a protein known as tubulin. Then what is the characteristic feature of this mitotic spindle, or what is the purpose of this mitotic spindle? The mitotic spindle is essential for the equal partitioning of DNA into the two daughter cells. Okay, so this mitotic spindle is very important for the equally dividing DNA into two daughter cells that are formed when a eukaryotic cell divides. Several plant-derived substances used as anti-cancer drugs disrupt this process by affecting the equilibrium between the polymerized and depolymerized forms of the microtubules, thereby causing cytotoxicity. So let's see the classification. So under this category, the drugs are mainly classified into two subdivisions. First one is taxane derivatives and second one is vinca alkaloids. Under taxane derivatives, the drugs include paclitaxel as well as docetaxel, and under vinca alkaloids, the drugs are vincristine, vinblastine and vinorelbine. First, we will see about vinca alkaloids, that is vincristine, vinblastine as well as vinorelbine. This vincristine is denoted as Vx and vinblastine is denoted as VBL. These are structurally related compounds derived from the periwinkle plant Vinca rosea. A less neurotoxic agent is vinorelbine, which is denoted as VRB. Although these vinca alkaloids are structurally similar, their therapeutic uses or their therapeutic indications are different. This Vx means vincristine. It is used in the treatment of acute lymphoblastic leukemia in children, Wilms tumor, Ewing soft tissue sarcoma, and Hodgkin and non-Hodgkin lymphomas, as well as some other rapidly proliferating neoplasms. Then VBL. VBL means vinblastine. It is administered with bleomycin and the cisplatin for the treatment of metastatic testicular carcinoma. It is also used in the treatment of systemic Hodgkin and non-Hodgkin lymphomas. Then VRB, which is the vinorelbine, it is beneficial in the treatment of advanced non-small cell lung cancer either as a single agent or with cisplatin. And in our previous slides, we have seen this RCHOP regimen. This VX means vincristine. The former trade name of this vincristine is oncovin. It is the O in the RCHOP regimen for lymphoma. Due to relatively mild myelosuppressive activity, vincristine is used in a number of other protocols. So coming to the mechanism of action of these microtubule inhibitors, these agents are cell cycle specific and phase specific because they block mitosis in the metaphase. So what do you mean by cell cycle specific? Cell cycle specific means these agents or these drugs are effective against rapidly proliferating or rapidly dividing cells. Okay, hence these microtubule inhibitors are cell cycle specific and space specific agents because they block mitosis in the metaphase. Their binding to the microtubular protein tubulin blocks the ability of tubulin to polymerize to form microtubules. Instead, paracrystalline aggregates consisting of tubulin dimers and the alkaloid drug are formed. The resulting dysfunctional spindle apparatus, frozen in metaphase, prevents chromosomal segregation and cell proliferation. Okay, so if you see the diagram, it will be more clear. So here you can see the normal mitosis. So in the normal mitosis, what will happen? See the metaphase. In the metaphase, the microtubules bind to the centromeres of the chromosomes. Here you can see the chromosomes. What do you mean by centromeres? These are the points where the sister chromatids attach. Okay, so this is what happens in the metaphase. And here you can see the tubulin molecules are stacked to form the mitotic spindle. Okay, this is the mitotic spindle. Now the next step is the anaphase. In the anaphase, the sister chromatids, okay, these are the sister chromatids. The sister chromatids are pulled apart, each moving toward a new daughter cell. Okay, so here there will be an equal partitioning of the sister chromatids will occur. So this is the anaphase and this is how normal mitosis occurs. Now let's see the case in the presence of vinca alkaloids. the mitosis blocked by Winkel alkaloids. So in the metaphase, what will happen? Here, tubulin molecules fail to polymerize in the presence of Winkel alkaloids. Okay, in the presence of Winkel alkaloids, the tubulin molecules cannot polymerize. Okay, so as a result, the anaphase will not occur. So as they cannot polymerize, the dissolution of the mitotic spindle leads to the cell death. Okay, so this is how Winkel alkaloids causes cytotoxicity. Now regarding the pharmacokinetics of Winkel alkaloids, IV injection of these agents leads to rapid cytotoxic effects and cell destruction. So this in turn can cause hyperuricemia. Hyperuricemia means increased uric acid levels, and this hyperuricemia is due to the oxidation of purines that are released from fragmenting DNA molecules. The Winkel alkaloids are concentrated and metabolized in the liver by the cytochrome P450 pathway and eliminated in bile and feces. Okay, so the elimination route of this Winkel alkaloids is bile as well as feces. So dose adjustment is required in patients with impaired hepatic function or biliary obstruction. Then these agents should not be administered intrathecally. If we administered through this particular route, this can result in death, and special precautions should be in place for administration. Now coming to the adverse effects, this vincristine and vinblastine are associated with a phlebitis or cellulitis if extravasation occurs during injection. Then as well as nausea, vomiting, diarrhea and alopecia. So these all are the common side effects associated with both vincristine as well as vinblastine. And other than this, regarding the specific toxicity, this vinblastine is a potent myelosuppressant, whereas peripheral neuropathy symptoms including paresthesias, loss of reflexes, food drop and ataxia, then constipation are more common with the vincristine. Okay, so the specific toxicity or the specific adverse effect associated with the vinblastine is myelosuppression, whereas the specific toxicities or the specific adverse effect associated with the vincristine is peripheral neuropathy and constipation. So we have completed Winkel alkaloids. So the next category is taxanes. Under taxanes, the two most common drugs are paclitaxel as well as docetaxel. So this paclitaxel was the first member of the taxane family to be used in cancer chemotherapy. Substitution of a side chain resulted in docetaxel, which is the more potent of the two drugs. This paclitaxel has good activity against advanced ovarian cancer and metastatic breast cancer as well as non-small cell lung cancer when administered with a cisplatin. This docetaxel is commonly used in prostate, breast, gastrointestinal and non-small cell lung cancers. Now regarding the mechanism of action, both these drugs, that is the paclitaxel as well as docetaxel, are active in the G2 bar M phase of the cell cycle. But unlike the Winkel alkaloids, they promote polymerization and stabilization of the polymer rather than disassembly, leading to the accumulation of microtubules. So when we have discussed about Winkel alkaloids, the mechanism of Winkel alkaloids is that they fail to polymerize. Okay, they fail to polymerize, but in case of taxanes, what these drugs will do, they promote polymerization. Okay, these taxanes promote polymerization and stabilization of the polymer rather than disassembly, leading to accumulation of the microtubules. Okay, so as a result, the microtubules formed are overly stable and non-functional. Okay, because of this overstability, the microtubules will become non-functional and the chromosome disaggregation does not occur. This results in death of the cell. Okay, so in a nutshell, we can say that this paclitaxel stabilizes microtubules, rendering them non-functional. The difference is that the Winkel alkaloids fail to polymerize, whereas this paclitaxel and docetaxel, they promote polymerization. Okay, they promote polymerization. So here you can see the image of normal mitosis, what we have already discussed. This is a metaphase. Here tubulin molecules are stacked to form the mitotic spindle, and next phase is the anaphase. Okay, here the spindle dissolves after the anaphase, allowing the cell to divide, and this mitosis is blocked by the paclitaxel. Okay, so here what these drugs will do, they will promote polymerization. Okay, so as a result, unusually stable tubulin molecules stack and fail to depolymerize. Okay, so the anaphase will not occur. Okay, cell remains in the metaphase, the anaphase will not occur. Now the pharmacokinetics, these agents undergo hepatic metabolism by the cytochrome P450 system and excreted via the biliary system. Okay, since these drugs are excreted through the biliary route, dose adjustment should be done in patients with a hepatic dysfunction. Then adverse effects. The dose limiting toxicities of paclitaxel and docetaxel are neutropenia and leukopenia. Then peripheral neuropathy is also a common adverse effect with the taxanes. Because of serious hypersensitivity reactions including dyspnea, urticaria and hypotension, patients who are treated with the paclitaxel should be pre-medicated with the dexamethasone and diphenhydramine as well as with an H2 receptor antagonist. So in this slide, you can see the summary of microtubule inhibitors. So we have discussed about Vinca alkaloids as well as taxanes and what all are the specific characteristic features of these particular drugs. Okay, what all are the route of administration, specific adverse effects, then is there any drug interactions, then what all are the monitoring parameters and is there any specific notes. Okay, so you can refer this image for further clarification as well as further details. So the next category of anti-cancer drug is steroid hormones and their antagonist. These drugs are active through the hormonal pathway. So under this category, the first one is estrogen and receptor modulators. Examples include ethinyl estradiol, diethylstilbestrol diphosphate, which is also known as phosphestrol. And the next class is selective estrogen receptor modulators. Examples include tamoxifen, toremifene. Then estrogen receptor downregulator. Example include fulvestrant. Then aromatase inhibitors such as letrozole, anastrozole and exemestane. Then anti-androgen drugs such as flutamide, bicalutamide and nilutamide. And at the last, GnRH, that is gonadotropin releasing hormone analogs, that is GnRH analogs. Examples include leuprolide, nafarelin and goserelin. So the first drug is tamoxifen. Tamoxifen is a selective estrogen receptor modulator. In short, we can say that it is an SCRM, that is selective estrogen receptor modulator. It is an estrogen antagonist in breast tissue and an agonist in other tissues such as bone and the endometrium. So normally the function of estrogen in the breast tissue is to promote breast growth, and in endometrium what this estrogen will do, it will promote endometrial growth. So this tamoxifen acts as a estrogen antagonist, that is this tamoxifen opposes the action of estrogen in the breast tissue, that is it inhibits or prevents the breast growth. Hence it is useful in the treatment of breast cancer, but it acts as agonist. Okay, the same action as that of estrogen in the endometrium, that is it promotes endometrial growth. So this tamoxifen is used as first-line therapy in the treatment of estrogen receptor positive breast cancer. It is also used for prevention of breast cancer in high-risk women. Then coming to the mechanism of action, this tamoxifen competes with estrogen for binding to estrogen receptors in the breast tissue and inhibits estrogen-induced growth of breast cancer. This results in depletion or downregulation of estrogen receptors, and the growth promoting effects of the natural hormone and other growth factors are suppressed. Then tamoxifen is effective after oral administration. It is partially metabolized by the liver. Unchanged drug and metabolites are excreted predominantly through the bile into the feces. And one important point, it is an inhibitor of CYP3A4 and P-glycoprotein. Now the adverse effects of tamoxifen include hot flashes, nausea, vomiting, skin rash, then vaginal bleeding and discharge. This is due to the estrogenic activity of the drug and some of its metabolites in the endometrial tissue. Then one important point, tamoxifen has the potential to cause endometrial cancer. As I have already mentioned in the previous slide, tamoxifen has agonist action in the endometrium. Okay, so the estrogen function in the endometrium is to promote endometrial growth. Okay, so as a result, tamoxifen also has the potential to cause endometrial cancer. This tamoxifen promotes endometrial growth. Other toxicities include thromboembolism and effects on vision. Now the next drugs include fulvestrant and raloxifene. This fulvestrant is an estrogen receptor antagonist that is given via intramuscular injection to patients with hormone receptor positive metastatic breast cancer. This agent binds to and causes estrogen receptor downregulation on tumors and other targets. Next drug is raloxifene. Raloxifene is also an oral selective estrogen receptor modulator that blocks estrogen effects in the uterine as well as breast tissues, while promoting effects in the bone to inhibit resorption. Hence, it is also useful in the management of osteoporosis. This agent reduces the risk of estrogen receptor positive invasive breast cancer in postmenopausal women. Both drugs are known to cause hot flashes, arthralgias, and myalgias. And next one is estrogens. A high dose of estrogen is known to reduce testosterone levels through the negative feedback mechanism in the hypothalamo-hypophyseal axis. The side effects associated with estrogens are stroke, myocardial infarction, pulmonary embolism, impotence, and loss of libido in man while treating for prostate cancer. Considering the side effects associated with the estrogens and availability of other safer alternatives, estrogen therapy is not used nowadays. Diethylstilbestrol, a synthetic estrogen, and its phosphate derivative, that is phosphestrol, are used for treating prostate carcinoma. Then under steroid hormones, the next category is aromatase inhibitors. The aromatase reaction is responsible for the extra-adrenal synthesis of estrogen from androstenedione, which takes place in liver, fat, muscle, skin and breast tissues including breast malignancies. So this peripheral aromatization is an important source of estrogen in postmenopausal women. So what these aromatase inhibitors will do, these drugs decrease the production of estrogen in this woman. So examples include anastrozole and letrozole. This anastrozole and letrozole are non-steroidal aromatase inhibitors. These agents are considered first-line drugs for the treatment of breast cancer in postmenopausal women. They are orally active and cause almost a total suppression of estrogen synthesis. Anastrozole and letrozole do not predispose patients to endometrial cancer. This is one advantage of this aromatase inhibitors, especially anastrozole and letrozole. Both drugs are extensively metabolized in the liver, and metabolites and parent drug are excreted primarily in the urine. Under aromatase inhibitors, the next drug is exemestane. It is a steroidal irreversible inhibitor of aromatase. This anastrozole as well as letrozole are non-steroidal aromatase inhibitors, whereas this exemestane is a steroidal irreversible inhibitor of aromatase. Then this exemestane is well absorbed after oral administration and widely distributed. And hepatic metabolism occurs via the CYP3A4 isoenzyme. Because the metabolites are excreted in urine, the doses of the drug must be adjusted in patients with renal failure. Major toxicities are nausea, fatigue and hot flushes. Alopecia and dermatitis have also been noted with this drug. And the next one is the GnRH analogs or the gonadotropin releasing hormone analogs, which includes leuprolide, goserelin and triptorelin. Then this GnRH is normally secreted by the hypothalamus and stimulates the anterior pituitary to secrete the gonadotropic hormones. The gonadotropic hormones are LH as well as FSH. LH means luteinizing hormone, the primary stimulus for the secretion of testosterone by the testes, and FSH, which is the follicle stimulating hormone, which stimulates the secretion of estrogen. This leuprolide, goserelin and triptorelin are synthetic analogs of GnRH. As GnRH analogs, they occupy the gonadotropin releasing hormone receptor in the pituitary, which leads to its desensitization and consequently inhibition of the release of FSH and LH. Thus, both androgen and estrogen synthesis are reduced. These drugs have some benefit in perimenopausal women with advanced breast cancer and have largely replaced estrogens in therapy for prostate cancer. Leuprolide is available as a subcutaneous daily injection, a subcutaneous depot injection or an intramuscular depot injection to treat metastatic carcinoma of the prostate. Then this goserelin acetate is a subcutaneous implant and triptorelin pamoid is injected intramuscularly. Levels of androgen in prostate cancer patients may initially rise but then fall to castration levels. The adverse effects of these drugs including impotence, hot flushes and tumor flare are minimally compared to those experienced with estrogen treatment. Next is the anti-androgens, drugs including flutamide, nilutamide, bicalutamide and enzalutamide. These drugs are oral anti-androgens used in the treatment of prostate cancer. These drugs compete with the natural hormone for binding to the androgen receptor and prevent its action in the prostate. Adverse effects include gynecomastia, constipation, nausea and abdominal pain. Rarely, liver failure has occurred with flutamide. Nilutamide can cause visual problems. So in this slide, you can see the summary of steroid hormones and their antagonist. You can refer this diagram for the specific characteristic features of steroid hormones and their antagonists. So in today's session, we have completed two more classification or two more categories of anti-cancer drugs, which includes the microtubule inhibitors as well as the steroid hormones and their antagonists. And the next class is the platinum coordination complexes. The drugs include cisplatin, carboplatin and oxaliplatin. The cisplatin was the first member of the platinum coordination complex class of anti-cancer drugs, but because of severe toxicity, carboplatin was developed. Cisplatin has synergistic cytotoxicity with the radiation and other chemotherapeutic agents. It has found wide application in the treatment of solid tumors such as metastatic testicular carcinoma, in combination with vinblastine and bleomycin, ovarian carcinoma in combination with cyclophosphamide or alone for bladder carcinoma. Carboplatin is used when patients cannot be vigorously hydrated as is required for cisplatin treatment, or if they suffer from kidney dysfunction or are prone to neuro or ototoxicity. Oxaliplatin is a closely related analog of carboplatin used in the setting of colorectal cancer. Mechanism of action of these platins are similar to that of alkylating agents. In the high chloride milieu of the plasma, cisplatin persists as a neutral species, which enters the cell and loses chloride in the low chloride milieu. So it then binds to guanine in DNA, forming inter and intrastrand crosslinks. The resulting cytotoxic lesion inhibits both polymerases for DNA replication and RNA synthesis. Cytotoxicity can occur at any stage of the cell cycle, but cells are most vulnerable to the actions of these drugs in the G1 and the S phases. S phase is the DNA replication or the DNA synthesis phase. Then coming to the pharmacokinetics, these drugs are administered via IV infusion. Cisplatin and carboplatin can also be given intraperitoneally for ovarian cancer and intra-arterially to perfuse other organs. The highest concentrations of the drugs are found in the liver and kidney and in intestinal, testicular and ovarian cells, but little penetrates into the cerebrospinal fluid. The renal route is the main pathway for excretion. Now moving on to the adverse effects. Severe persistent vomiting occurs for at least 1 hour after administration of cisplatin and may continue for as long as 5 days. So pre-medication with the antiemetic agents is required. The major limiting toxicity is dose-related nephrotoxicity involving the distal convoluted tubule and collecting ducts. This can be prevented by aggressive hydration. Other toxicities include ototoxicity with high frequency hearing loss and tinnitus. Unlike cisplatin, carboplatin causes only mild nausea and vomiting, and it is rarely nephro, neuro or ototoxic. The dose limiting toxicity is myelosuppression. Okay, so the dose limiting toxicity of carboplatin is myelosuppression, whereas the dose limiting toxicity of this cisplatin is nephrotoxicity as well as ototoxicity and neurotoxicity. This oxaliplatin has a distinct adverse effect of cold-induced peripheral neuropathy that usually resolves within 72 hours of administration. It also causes myelosuppression and cumulative peripheral neuropathy. Hepatotoxicity has also been reported with the oxaliplatin. These agents may cause hypersensitivity reactions ranging from skin rashes to anaphylaxis. Then in this slide, you can see the summary of platinum coordination complexes. That is what all are the route of administration, their specific adverse effects, the notable drug interactions, monitoring parameters as well as the specific points associated with each drug. That is cisplatin, carboplatin as well as oxaliplatin. So the next classification is the topoisomerase inhibitors, which can be subdivided into two groups. That is the topoisomerase 2 inhibitors and topoisomerase 1 inhibitors. Topoisomerase 2 inhibitors examples include etoposide and tiniposide, whereas topoisomerase 1 inhibitors examples include topotecan and irinotecan. So the mechanism of action of these drugs is by the inhibition of topoisomerase enzymes. So what do you mean by these topoisomerase enzymes? These enzymes belongs to a class of enzymes that reduce the supercoiling of DNA. So the function of this topoisomerase enzymes is to reduce the supercoiling of DNA. And what these drugs will do? These drugs, that is the topoisomerase inhibitors, inhibit the topoisomerase enzymes. So under this topoisomerase 1 inhibitors, they are also known as camptothecins. These camptothecins are plant alkaloids originally isolated from the Chinese tree Camptotheca. Irinotecan and topotecan are semi-synthetic derivatives of camptothecin. Topotecan is used in metastatic ovarian cancer when primary therapy has failed and also in the treatment of small cell lung cancer. Whereas this irinotecan is used with 5-fluorouracil and leucovorin for the treatment of colorectal carcinoma. So if we say more specifically, these topoisomerase inhibitors are S-phase specific. We have already discussed the cell cycle, and S-phase is the DNA synthesis phase. Okay, so these drugs are S-phase specific and inhibit topoisomerase 1, which is essential for the replication of DNA in human cells. SN38, it is the active metabolite of irinotecan. Okay, so the active metabolite of irinotecan is SN38. It is approximately 1,000 times as potent as irinotecan as an inhibitor of topoisomerase 1. The topoisomerases relieve torsional strain in DNA by causing reversible single strand breaks. Then coming to the adverse effects, the most important one is bone marrow suppression, that is myelosuppression, and next is the neutropenia. Neutropenia is the dose limiting toxicity for topotecan. So frequent blood counts should be performed in patients receiving this drug. Myelosuppression is also seen with irinotecan. Acute and delayed diarrhea with irinotecan may be severe and require treatment with atropine during the infusion or high doses of loperamide in the days following the infusion. Next, we will see about etoposide, which is a topoisomerase 2 inhibitor. It is a semi-synthetic derivative of the plant alkaloid podophyllitoxin. This agent blocks cells in the late S2 G2 phase of the cell cycle, and the major target is topoisomerase 2. So binding of the drug to the enzyme DNA complex results in persistence of the transient cleavable form of the complex and thus renders it susceptible to irreversible double strand breaks. Okay, so here you can see this is the normal catalytic cycle of the topoisomerase, what these drugs will do. And what this etoposide will do, it leads to double strand breaks in DNA, as a result formation of irreversible double strand breaks in the DNA. So major clinical use in the treatment of lung cancer and in combination with the bleomycin and cisplatin for testicular carcinoma, this etoposide is administered either IV or orally. Dose limiting myelosuppression, primarily leukopenia, is a major toxicity. Leukopenia means reduced white blood cell count or reduced level of leukocytes. And next topoisomerase 2 inhibitor is teniposide. Okay, it is another derivative administered by the intravenous route. It has got longer terminal half-life compared to etoposide. The mechanism of action is almost similar. It is used for the refractory ALL. ALL means acute lymphoblastic leukemia in children. Apart from gastrointestinal side effects, myelosuppression has also been associated with its usage. And this slide is about the summary of topoisomerase inhibitors. So far we have discussed the most or the major categories of anti-cancer drugs, and the next one is antibodies, that is a monoclonal antibodies. These monoclonal antibodies are an active area of drug development for anti-cancer therapy and other non-neoplastic diseases because they are directed at specific targets and often have different adverse effect profiles as compared to traditional chemotherapy agents. Monoclonal antibodies also find application in a number of other disorders such as inflammatory bowel disease, psoriasis, and rheumatoid arthritis. So all of these agents are administered intravenously and infusion related reactions are common. So regarding the monoclonal antibodies, here you can see the summary. Okay, so these all are the major monoclonal antibody drugs that are used for cancer therapy. Examples include bevacizumab, cetuximab, daratumumab, ramucirumab, rituximab, and trastuzumab. Always remember the names. Okay, it is very important that suppose in case of exam, you should be able to identify which drug belongs to which category. Okay, so you should be able to identify these all drug belongs to the monoclonal antibodies. Okay, and you can read the mechanism of action, adverse effects, monitoring parameters, as well as the specific points related to each drug. Next category is the tyrosine kinase inhibitors. These tyrosine kinases are a family of enzymes that are involved in several important processes within a cell, including signal transduction and cell division. So at least 50 tyrosine kinases mediate cell growth or division by phosphorylation of signaling proteins. They have been implicated in the development of many neoplasms. The tyrosine kinase inhibitors are administered orally, and these agents have a wide variety of applications in the treatment of cancer. So here you can see the summary of tyrosine kinase inhibitors. As I have already mentioned in case of monoclonal antibodies, remember the names. Okay, so here it is an easy method, that is all these drugs, that is all these tyrosine kinase inhibitors. Most of these tyrosine kinase inhibitors end in the word NIP. Okay, so this will help you to easily identify the drugs that belongs to tyrosine kinase inhibitors. And you can just go through the mechanism of action, adverse effects, drug interactions, monitoring parameters, as well as the specific notes related to each drug. And this slide is a continuation of the previous slide. Okay, just see this. Okay, most of these drugs, that is nilotinib, that is pazopanib, most of these drugs end in the word nib. Okay, so remember that those drugs, Okay, that, and in the word NIP, that will belongs to tyrosine kinase inhibitors. That will help you to easily identify these drugs. And the next one is the immunotherapy. So this immunotherapy with intravenous immune checkpoint inhibitors is a rapidly evolving option for cancer treatment. The goal of immune checkpoint inhibitors is to block the checkpoint molecules such as the programmed death receptor that normally help to keep the immune system in check. So by blocking these checkpoint molecules, the immune system is better able to attack the tumor and cause destruction. The two most commonly used checkpoint inhibitors are pembrolizumab and nivolumab. The adverse reaction profiles of these agents consist of potentially severe and even fatal immune-mediated adverse events. This is because turning off the immune checkpoints allows attack of the tumor but can also lead to unchecked autoimmune response to normal tissues. Then adverse events include diarrhea, colitis, pneumonitis, hepatitis, nephritis, neurotoxicity, dermatologic toxicity in the form of severe skin rashes, and endocrinopathies such as hypo or hyperthyroidism. Patients should be closely monitored for the potential development of signs and symptoms of toxicity and promptly treated with the corticosteroids if necessary. Now we will see some miscellaneous agents. So the first one is abiraterone acetate. This is an oral agent used in the treatment of metastatic castration-resistant prostate cancer. This drug is used in conjunction with prednisone to inhibit the CYP17 enzyme. This is an enzyme required for androgen synthesis, resulting in reduced testosterone production. Hence, it is useful in the treatment of prostate cancer. So, co-administration with prednisone is required to help lessen the effects of mineralocorticoid excess resulting from the CYP17 inhibition. Hepatotoxicity may occur, and patients should be closely monitored for hypertension, hypokalemia, and fluid retention. Joint and muscle discomfort, hot flushes, and diarrhea are common adverse effects with this agent. Then certain immunomodulating agents, for example thalidomide, lenalidomide and pomalidomide are oral agents used in the treatment of multiple myeloma. Their exact mechanism of action is not clear, but they possess anti-myeloma properties including anti-angiogenic, immune modulation, anti-inflammatory and anti-proliferative effects. These agents are often combined with the dexamethasone or other chemotherapeutic agents. Adverse effects include thromboembolism, myelosuppression, fatigue, rash, and constipation. Thalidomide was previously given to pregnant women to prevent morning sickness. However, severe birth defects were prevalent in children born to mothers who used thalidomide. Lenalidomide and pomalidomide are structural variants of thalidomide, and because of their structural similarities, these drugs are contraindicated in pregnancy. So the next one is proteasome inhibitors. Examples include bortezomib, ixazomib, and carfilzomib. These drugs are proteasome inhibitors commonly used as a backbone therapy in the treatment of multiple myeloma. These agents work by inhibiting proteasomes, which in turn prevents the degradation of pro-apoptotic factors, thus leading to a promotion in programmed cell death, or these drugs will cause apoptosis. Malignant cells readily depend on suppression of the apoptotic pathway. Therefore, proteasome inhibition works well in multiple myeloma. Bortezomib can be administered intravenously, but the subcutaneous route is preferred because it is associated with a less neuropathy. Other adverse effects include myelosuppression, diarrhea, nausea, fatigue, and herpes zoster reactivation. So, patients should receive antiviral prophylaxis if they are receiving therapy with the bortezomib. Okay, so this is an important point. One of the major adverse effects associated with this bortezomib is it can cause herpes zoster reactivation. Okay, so patients should receive antiviral prophylaxis if they are receiving therapy with the bortezomib. Then ixazomib is an oral agent with an adverse effect profile similar to bortezomib. Carfilzomib is administered intravenously, and common adverse effects include myelosuppression, fatigue, nausea, diarrhea, and fever. So in this slide, I have mentioned the summary of toxicity of chemotherapeutic agents. As I have already discussed, along with this classification of anti-cancer drugs, specific toxicities associated with this anti-cancer drugs is very important. So first one is cisplatin. The specific toxicities related to cisplatin are ototoxicity, nephrotoxicity, and nausea and vomiting. And this bleomycin and busulfan causes the pulmonary toxicity. Then cyclophosphamide and ifosfamide, major toxicities, hemorrhagic cystitis. In order to prevent this problem, these drugs are usually co-administered with a mesna. The cytarabine causes the chemical conjunctivitis. Doxorubicin and daunorubicin is associated with the cardiotoxicity. This oxaliplatin, vincristine and taxanes causes peripheral neuropathy. And the major toxicity associated with the irinotecan is diarrhea. So we have completed this anti-cancer chapter. If you have any doubts, you can post or you can share your valuable comments in the comment section. For more details, you can refer Lippincott textbook for pharmacology. If you find this video useful, please like, share and subscribe. Thank you everyone for watching this video. Have a good day.